Hi, my name is Fouad Otaki. I'm an assistant professor of gastroenterology and hepatology at Oregon Health and Science University. On behalf of my co-authors, I'd like to thank the editorial board at Gastrointestinal Endoscopy Journal for the opportunity to discuss our article titled Outcomes of Patients with Submucosal Esophageal Adenocarcinoma, a Multicenter Cohort Study. There's a global consensus in consistent literature on the use of endoscopic multimodal therapy in the treatment of intramucosal esophageal adenocarcinoma. Mucosal resection offers staging and histological prognostication, while subsequent endoscopic ablation significantly reduce the risk of metachronous lesions. Endoscopic therapy does not address frank or micrometastasis to regional or distant lymph nodes, and complications of endoscopic therapy, while infrequent, are also mild. In parallel, surgical therapies have also significantly improved, particularly in high-volume centers with reductions in mortality, morbidity, and improvements in quality of life scores. Radiochemotherapy protocols are also now more tailored and effective. Submucosal esophageal adenocarcinoma is a diagnosis that would greatly benefit from a personalized approach. Historically managed with an esophagectomy combined with neoadjuvant chemoradiotherapy, studies have shown that roughly 20% of these patients have no evidence of cancer at the time of esophagectomy. This has encouraged many specialized centers, including ours, to explore the role of endoscopic treatment of low-risk cohorts. Key factors predictive of improved outcomes include shallow depth of invasion into the submucosa, degree of differentiation, and the absence of lymphovascular and perineural lymph nodes. Submucosal adenocarcinoma is a diagnosis that greatly benefits from a personalized approach. Historically managed with an esophagectomy, combined with neoadjuvant chemoradiotherapy, studies have reported roughly 20% of these patients having no evidence of cancer at the time of esophagectomy. This has encouraged many specialized centers, including ours, to explore the role of endoscopic treatment of low-risk lesions. Key factors predictive of improved outcomes include shallow depth of field into the submucosa, degree of differentiation, and the absence of lymphovascular and perineural invasion. Our cohort study involved 3 tertiary care centers: Mayo Clinic in Rochester, Minnesota, University of Pennsylvania, and Columbia University. Only patients with true submucosal invasion were included. We excluded patients that received neoadjuvant therapy and those that were understaged by histology. Finally, patients lacking follow-up, which we defined as less than 10 days. Kaplan-Meier limit model was used for survival analysis, and the variables of interest included demographic and histological factors. Clinically relevant and statistically significant variables were used for the multivariable analysis. In total, 141 patients were included, all of which underwent EMR at our test centers. And interestingly, 86% of them had at least one high-risk histological feature. Staging was performed with EUS in 90% of cases, while PET-CT was done in 84%. Of the 141 patients, 48% underwent an esophagectomy, while 52 were treated endoscopically. And in total, 17 received adjuvant chemoradiation after the initial endoscopic resection. Of the surgeries, 63% were done through an Ivor-Lewis technique. All of them had negative histological margins. And interestingly, 43% did not have any cancer cells at the time of surgery. That said, 15% did have lymph node metastasis. Follow-up was slightly over 4 years, and the 30-day perioperative mortality was around 3%. The endoscopic cohort was followed for a slightly shorter period of time. 41% of them received additional ablative therapy, most commonly radiofrequency ablation, while 63% achieved endoscopic cancer remission. Patients in the surgical group tended to be younger and were more likely to be male with a lower comorbidity score, while patients in the endoscopic group had longer Barrett's segments and were more likely to receive chemoradiation. Overall, 5-year survival was significantly higher at 89% in the surgical group compared to 59% in the endoscopic group. However, cancer-free survival 5 years after remission, though numerically higher in the surgical group, was not statistically significant. In our analysis of predictors, esophagectomy was associated with lower overall mortality, while older age, comorbidity, and deep margin positivity on the mucosal resection were associated with increased overall mortality. 10 patients had cancer recurrence after remission, 6 of those in the endoscopic cohort and 4 in the surgical cohort. Esophagectomy was associated with a lower risk of cancer recurrence. That said, all the recurrences in the endoscopic cohort were mucosal adenocarcinoma and managed endoscopically. Having one histological high-risk factor, which we defined as dedifferentiation, presence of lymphovascular invasion, and deep margin positivity, was associated with decreased 3- and 5-year survival compared to the group without any such features. While our study is a large cohort study, we acknowledge the many limitations, mostly of its retrospective design, and most notably referral bias despite our various adjustments. We were also unable to include submucosal depth of invasion in micrometers or tertiles, as this is not part of our standard practice. And finally, every effort was made to identify cause of mortality, but unfortunately, the exact cause of death was unknown in the majority of patients. In conclusion, our multicenter study found esophagectomy to be associated with improved overall, but not cancer-free survival. And while possibly underpowered, our collective 15-year experience is the largest such series of histologically well-characterized submucosal esophageal adenocarcinoma. We report outcomes of an endoscopic group that is relatively high risk. We believe that the care of such patients continues to be served by centers of excellence, and the role of chemoradiotherapy in this group warrants further research. Thank you for your interest in our study, and we invite you to read the rest of the manuscript for detailed results and analysis.